Hello. Right, we better start this session. Welcome everyone. Firstly, my big thank to the panel to be here on a. I don't think we should interfere with a patient's appointment, but so for taking Friday afternoon and being with us. This is one of many of our engagement sessions with experts, with Londoners, with all sorts of different stakeholders, and we have two sessions today. It's going to last for about an hour. It's a slightly different format than the last one. It's very much an interactive session on a couple of themes for the first hour, and then we're going to move on to a different themes for the second session. So I'm also delighted to see many people here. I suspect clinical background, maybe patients, maybe members of the public, and welcome. And I hope you will find this at least informative. But I really look forward to some of your thoughts at some stage during the discussion as well. So, if I could very briefly go and introduce ourselves. Arad Darzi is my name. I'm the person have the privilege of chairing the London Health Commission, which reports to the Mayor. And let's start from there.
Hello, yes, I'm Claire Murdoch and I'm Chief Executive of Central and North West London Foundation Trust, and we provide mental health, addiction and community services across a large part of London.
I'm Muir Gray and I chair the Digital Service Board, NHS Choices and everything to do with that for the NHS, and the other part of my life is trying to turn the health service into a set of systems, not a set of institutions.
Good afternoon, I'm Paul Wallace. I'm a GP by training, a professor of primary care. My main interest is around alcohol, and particularly early identification and brief advice for alcohol problems. And I chair a group called the London IBA Strategic Leadership Group, which is trying to get these in place across London.
I'm Liz Bruce. I'm the Exec Director for Triborough Adult Social Care and Health, and we deliver services to elderly people, disabled people across those three London boroughs.
Hi, I'm Crystal Oldman. I'm the Chief Executive of the Queen's Nursing Institute, and I'm a community nurse by background.
Hi, I'm Anne Rainsbury. I'm the Regional Director for NHS England in London.
I'm James Riley. I'm the Chief Executive of Central London Community Healthcare, an organisation which delivers community healthcare from the cradle to the grave, as it were, in the three central London boroughs that we're present in today: Westminster, Kensington, Chelsea, Hammersmith and Fulham, but also in Barnet in North London. I've been in that role for 3 years, and prior to that I was a serving Director of Adult Social Care and other things in local government.
My name is Meriden Peachy. I'm the Director of Public Health for the Triborough Councils in London, which is Kensington, Chelsea, Hammersmith and Fulham and Westminster. I've been here for around 7 weeks now. My job is around health improvement of the population of those boroughs, and that includes ensuring that people are protected from threats of disease, health improvement and healthcare advice.
My name is Bill Lynn. I'm an infectious diseases doctor out at Ealing Hospital in West London and chair the Clinical Leadership Advisory Group for Tuberculosis in London, and we want to reduce the rate of TB in London substantially over the next few years.
I'm Lynn Altas. I'm the London TB Network Manager, working on implementing the London TB model of care.
Mark Spencer. I'm GP by background. I'm now Deputy Medical Director in the Regional Office of NHS England. And over the last few years I've been leading on service change and reconfiguration, particularly across North West London, improving primary care, changing hospital landscape.
I'm Tim Briggs. I'm an orthopaedic surgeon from the Royal National Orthopaedic Hospital at Stanmore. I'm current President of the British Orthopaedic Association and Chair of the Federation of Specialist Hospitals, a number of which we have in London. And I'm also chairing the national pilot Getting It Right First Time, which will transform, I think, orthopaedic care in England.
Thank you. So, thank you everyone, and I think the first theme, as you've seen from the expertise of the panel, is about better health, which is a theme that's really building momentum in London, mostly around the challenges of prevention. How do we deal with this burden of disease if we don't have a set of evidence-based interventions in the area of health and well-being and prevention? So I'm going to start with Muir. This is a very passionate area of his, to give us some thoughts. We've been trying to do this, Mew, for a long time in London.
Yes.
We've had some successful campaigns, but not necessarily uniform across London. London has some of the biggest challenges when it comes to health inequalities, if we compare it to the rest of the country. So we're very keen to find out what you think we should do, very much really taking, giving regard that we're dealing with a capital city, which brings in all sorts of other challenges.
I see this as the third health revolution. The first health revolution in London was the public health revolution. The sewers and the water are fantastic. We've had the second revolution, high tech, hip replacement, cataract, chemotherapy. But the third health revolution is underway, and it's driven by three forces: citizens, knowledge, and this. And I usually ask middle-class audiences how many of you don't have one, and there's always some. And I say three things: poor people have this, poor people sure as hell know how to use a mobile phone, and we're all going to have this. Now, in the digital health service, we're already getting more people coming to NHS Choices than go to GPs in the course of a day. But we've only started to use this in different sort of ways. My estimate is in London there's probably 100 million lab reports and maybe 200 million letters sent out, and I don't see any good knowledge in any of them. I've been in discussion with East London, with BARTs and the GPs in East London, and I'd suggest we need to think of a digital approach. And that, in my experience, means getting young people involved, getting people from other backgrounds. People who can't read English can listen to podcasts. So I'd suggest for this area, actually more than the other areas, I think technology. But then to finish, I'd say, digital healthcare, I don't like it. It's like saying electric healthcare. Of course it's electric. Of course it's digital. Why is it someone said to me, my hairdresser can send me reminders to do things and not the NHS? The answer? Hairdresser's been to university for 5 years and 6 years of postgraduate education. That must be the reason. So the NHS is about 10 years off the pace. So that would be my suggestion. Engage with the citizens directly, not necessarily geographical communities, but we work with mobile phone companies.
Okay. Any thoughts?
So one of the things we've been grappling with is childhood obesity in London. So that is all the projections is that is increasing at an unprecedented rate, and it's with the childhood obesity capital of Europe. So just develop that thought a bit further, Mia, in terms of the interrelationship between what you're suggesting, because some of the things that have been said to us about is how do we make choices, healthy choices, easy. So the sorts of things that have been presented is, should we look at, say, regulation around schools in relation to fast food outlets? Is there something that could be done with the curriculum in schools? What are the opportunities to work with London boroughs? Do you have thoughts on that?
One thing to open up with, but lots of people around the table and in the audience will have more ideas. This was, I run a little charity called the National Campaign for Walking, because actually it's exercise rather than calories is the key issue. And a colleague ran a project in South London where they put monitors on the lampposts, and they got the kids to walk, and there was better social interaction, and they gave them cinema tokens and a whole variety of things. Again, as young people say, when will the NHS get the message? My generation doesn't do envelopes. So I think for here, I think there are ways in which you could dramatically increase the amount of. One must never use the word walking with young people, mind you. You've got to keep it very quiet. So, but we are the ethics of this. If people agree they have a long-term objective of staying healthy, then we can use behavioural economic techniques. So, again, I think we should just do something, get some young people in. And how could we get young people in London to walk 1 million extra steps in the next 4 years? We could have an Olympic challenge for them and link it to some charities to some poor country. I'm making it up, but you can see things that could be done very simply. And I'm an old guy, but even I can work the step jockey and the walking app.
There's some ideas around that, where at the moment, from the evidence, which is the use of Oyster cards and things like that, and see whether you can get some rewards as well. We've seen that in some of the evidence returns. But let's build on this, because there's something in this.
Well, no, I only wanted to say that in the area that I'm interested in, alcohol, similar sorts of approaches, we are doing quite a lot of work looking at when you put resources for behavioural change for alcohol on the internet, and that is a very rapidly growing field, for which there is a growing evidence base. You were asking about evidence, and there is an evidence base that suggests that certainly people who are motivated to change, it's not quite the same as people who aren't motivated to change, but putting it up there, and I think some imaginative uses of that kind of thing. One of the things, I don't now work as a GP, but you could imagine having something in parallel to the face-to-face contact that you have with your GP, going on around behavioural interventions that you could access here in this kind of space. So the idea of having, you've already got a touch screen, but why not have a tablet or something in the waiting room where you can actually access all sorts of things, including those kinds of online resources for exercise, diet, behavioural change in terms of alcohol. And I think some of those kinds of things, that approach needs to be experimented. One of the things that we want to do in this group is to identify online resources that anybody anywhere can access for screening and brief interventions, whether they're questionnaires, things like the Audit C, which is just 3 questions, or whether it's brief intervention packages that people can use either in a printed form, but much more likely, as Muir says, on their phone.
Up to the age of 80.
And beyond.
All online, yeah.
We have a project with very old people using iPads, and they love it.
Sorry, yes.
Yeah, I think this all sounds really, really positive. One of the challenges that I can see in some of this, because it's really positive for the patients, families, children, what do you think is the state currently of the use of mobile technology and mobile working within our systems? Because my sense is that we're certainly not there yet. And what do you think might need to be done to get us there rapidly in London?
Yeah, I think at least we've stopped putting up signs saying, please do not use your mobile phone or you'll kill everyone in ITU. I think that has been no longer there. The professionals, Mr. Gates said the key question for the 21st century is to ask what's the function of the human being? And the function of the human being is not to remember things, because it's very difficult, not to keep up to date, not to give information necessarily, because we know people can't remember, is to help people reflect. I was just saying to Tim, the work he's been doing, we had personalised medicine long before the genome, listening to people coming for a gallbladder operation or whatever. Yeah. So it's back to good old listening. What's the problem that you've got? Can I listen? Not what's the diagnosis that you've got, the problem you've got. So I think there's a need to reaffirm the role of the human being, and of course nursing would probably be ahead of medicine in thinking that. But it's not information giving. It's not helping people with probabilities, because we could do that better this way. But it might be holding the hand of someone in reflection. So good old consulting skills, I would say, would be very high on the list of techniques we need to go back to.
I'd like to just pose 2 questions. One, endorse the view, our experience in community healthcare, an app on COPD for young people, very, very impactful. The take-up for chlamydia immunisations, etc., for younger people through school nurses, hugely helped us do that just through text messaging, etc., to do that. So there is growing evidence that people respond to that. My 2 questions are, one, we know that world is now populated, it's an open world. People can make all sorts of apps of any, and they can be generated anywhere. How do you accredit to trustworthy and safe, evidence-based positions? One challenge, and yet not begin to overcomplicate the whole thing. Number 2, London is proud of its growing reputation as a tech innovative city, driving the bow wave of this. How can somebody like the mayor capitalise or mobilise that kind of movement to bring it to bear on health and well-being?
Good point, yeah.
The approach we took in the past was that to say every organisation should have a chief knowledge officer. That's someone at board level. It's a role, not a job, who thinks, what sort of organisation what sort of knowledge does my organisation give? Yeah. And of course the public will go and look everywhere, but we've got to compete. So of the 150 million letters a year that go out in London, how many of them have got useful information? A couple of thousand, I would guess. So we compete, and every organisation would have to have someone at board level who understands this world, just probably a medical director or nursing director. Yeah. And then the second point, the digital care service, let's just have a big hack day somewhere about the Old Street roundabout. Let's get the youngsters together, and I don't know if you'd planned that for the commission, but Tim Kelsey and I would be very pleased to do. Let's have a London hack day. Is terribly cool, you know. It's a very cool thing to have. So we'll have a hack day and see what happens.
Yeah.
Well, thank you.
Yeah, I like so much of what you've said, because I suppose thinking about healthcare in a world city like London, which I'd really like to take the chance to say now, I think is a wonderful city. I feel very privileged to live and work here. I think it's a brilliant city. But you do almost want to pitch care at the cutting edge of technology and innovation. And I agree with you. I think we can be dripping with prejudice about who does and doesn't access technology. And actually, if you're an elderly couple wanting to Skype your grandchildren in Australia, you're using technology. So we've got to stop pigeonholing who does and doesn't have technology. And at the other end, we want to be seen, I think, as a deeply human and compassionate city. And so I like so much about what you've just said about, is it possible to be both? And actually it's deeply possible to be both. Technology will open up the doors to this multicultural city, the language differences. We're going to be able to all speak to each other much more easily because of technology, bring the human connection together despite a language barrier. And how many people are here today, including the experts around this table, and I count myself as included in this question, who do things on a health front because they should? How many have a glass of wine too many knowing they shouldn't? In my case, a bar of chocolate too many knowing I shouldn't. Don't jump in a cab when they should be walking somewhere. We seldom do things because we should with our health. We do it because it's fun or we've got other motivations. So I really think that the relationship between psychology, emotion and physical health is something that is underexplored, underexploited and not understood enough, which is one of the very great excitements of a trust like mine, but working with other colleagues around how far can we push the bounds of understanding, avoiding long-term conditions, managing them differently when you have them. And at the heart of it has got to be a deeper understanding of behaviour and health and illness, and I think we underexploit it, and we absolutely should think harder about how we bring that together. If I can, just one tiny example. In one of our A&E departments a while ago, 100 patients, well, it was several A&Es that we work in, 100 patients made for 3,500 visits in a year. And we cut that by 1,000 by working with those people psychologically. And most were coming with medically unexplained symptoms or real medical symptoms, COPD and other things. But what we were doing was not working with the psychology and the emotion of the person with the physical illness. We all know we should do it. I suggest we fail to do it, and that should be one of the big pushes of the next 10 years.
Liz?
I think the use of modern technology and some of the examples that you've shared are absolutely right, but that's going to be a bit of a longer journey to change behaviour and to get into a routine of this is how we do it. And here and now, part of our problem or challenge in health and care is the demand management and the volume. And again, I think technology can be part of the solution, not the whole solution, but at the front end of the patient journey or customer journey, managing demand in a different way, self-serve, that technology in the community in terms of learning about conditions and how we self-care, because we've got a here and now problem, haven't we? And then a longer journey to go on. But using modern technology and thinking about modern in public sector, the two often don't go together. And if anything, I think London Health Commission should really influence the fact that iPads and mobile phones and texting is the way to actually engage with people.
Thank you. Yes, please. So the ladies first.
Okay.
Yeah.
Personally, I'm working with Fulham Football Club Foundation at the moment. My background is sport. I've worked in sport development and lead sport for a long time.
Yep.
And in my observation, I think there needs to be more linkage in terms of the problems like childhood obesity and trying to influence behaviour, which is something you were coming up with in your point there. I think it's now getting beyond the role of health sitting in the NHS and perhaps a way forward be to look at more partnerships with other sectors such as the leisure sector, the sports sector, because somebody can see an app on their phone, but where's the catalyst? A lot of the driver from sport is not just the fitness, it's the socialisation, it's doing something you enjoy, and the other things come as secondary benefits. Now, what's going to be the catalyst to get a kid to walk to school? Well, they'll do it if their mates will go to school, and the mum will let them do it if they think it's safe. So if that's the type of thing to move forward, that it sits beyond the realm of just the NHS and needs to be partnership working with other parts of the community and services in the community.
Very, very good point. And I think Liz will come back to that, because it's not how do you get all your powers here. It's not just health, it's education.
Absolutely.
And the rest of the community.
The wider determinants of health and that multi-agency working at a place level, and part of the work around whole systems and joining up care needs to go outside of the formal boundaries of care into the community and way upstream, where people work together across the patch to support each other. I absolutely agree with you, and integrating or locating the solutions in the right place together, working together to drive that.
Yeah, we've got one other question, we'll come back. It's a really fascinating discussion. My name's Jacob Nash. I also work for the Fulham Football Club Foundation, not to want to dominate this from Fulham point of view, but
where's Fulham in the league?
We're not dominating anything.
Wrong question. Yeah, sorry. Yeah. Okay.
You
Yeah.
noticed I didn't describe us as a Premier League football club at the moment, but we are still. So fascinating to hear what Professor Gray had to say about digital technology, using that, and especially linking that to physical activity. I just want to bring an example that might illustrate one way in which we can do this, and I encourage the Commission to think about this. Recently on Kickstarter, there was a mobile application that has used the culture that currently exists, that you will see on the London Underground everywhere, of people on their iPads and their iPhones playing what's called massive multiplayer online games, where they take part in huge kind of kingdoms and capture territory of one another. And these literally, there are millions and millions of people in this country that play these games, okay? And it can be a substitute for physical activity. On Kickstarter, for £15,000, a couple of guys came up with an idea called Run an Empire. And the idea of this is that rather than capture territory from people on an online game, you capture territory from your neighbourhood, around your neighbourhood, by running and walking your neighbourhood or walking to school. And it bitmaps that and GPSes it and puts it into a programme and shows you. Now, one of the things that I've been to commissions before, and I've heard people talk in this way, and when we hear digital technology, one of the first things that we think of is that we think we must create something and this must go to an iPad or an iPhone. I think the thing that we need to think of is, what about culture and what about digital technology can we actually piggyback on that is already there? Because I actually think a lot of this stuff is already here, and because of what we do every day, and we're not all young and aware of what all the different applications are that we can use, we actually neglect the fact that some of the solutions are there, and we need to be the catalyst, as Claire said, the kind of social, cultural catalyst to move people towards using them.
Thank you. Yes.
I just think it's whole fascinating, the whole area of communication, particularly around health and what it is about inequalities. And I think whether we call it digital communication or not, I think it's about communicating where people are at, what means something for people's lives, and whether it be the iPad or the iPhone or something else. And I'll just give an example of if you do change to different type of technology. I mean, I gave a presentation at a conference and it was called Find a Condom app. But it's fine having the app, and young people designed it, very young people designing it themselves, and it was used massively. But unless you change all the services behind that to actually work with it, then you're not going to get the change. So, for example, to go with that, this is an example that we had in Kent. We had 500 C-card points where people could get free condoms, which was what you find the condom app was for. But what it was about children's centres, it was about community services, it was about pharmacies and others actually helping with first-line sexual health advice. And actually all of youth services were trained. So it's actually changing the services behind the technology to go with it. So I think there's something about the messages. And I think one of the issues around child obesity, I think absolutely right, it's got to be a whole system behind it, and it could be, for example, housing officers. And if you think of every contact counts, if housing officers can see I've got a young family, I've got children, actually where can they get nutrition support? Do they smoke? And I've talked to the police about actually, do you recognise every contact counts? And actually some of them said yes. There is things we can do while we're there. So I think there are a number of things around actually making things relevant for people's lives and where they are. And just today I was with an organisation called Qua Africa. And it's working inside the communities with people with HIV and AIDS. And a lot of these people are too frightened to go to services. They're too frightened to go and get tested for early HIV testing, but they will talk to people in their own community. And it was the faith community that were actually helping these communities get lots of testing. So I think it's got to be where people are at, and I think we need to be a bit smart about that.
Fantastic. Yes.
So I think there's some fantastic ideas here. I think one of the challenges for the Commission is I'm aware, obviously, in where I work, that there are local networks, such as the one you might belong to, etc., where some of these initiatives take flight through local champions and initiatives, such as you might be literally around this patch. You could develop these. One of the challenges for us is what can the Mayor, with his powers and his influence, do that might make this happen across the piece? If London is going to be a healthier city across the piece, could you develop some of your thinking and think, I'll give you an obvious example. So there's more exercise happening in London because of the Boris bikes, because a whole network is developing and evolving to make cycling a more acceptable form of transportation in this. So you can absolutely land that as a credit to the mayoralty for that. Are there any other ways in which you can think of the scale of what a London-wide authority like the mayoralty has that could advance some of the things you're thinking about?
There are two things I think we need to finish on. One is, how do we scale this up? How do we get 32 councils to be aiming on a similar theme? And what's the added value of the mayor? But I also would like to bring in, another 10-15 minutes we have, is how are we going to fund this between the 32 councils and the NHS? So any thoughts on the first one?
Yeah, we did suggest this at when I was my child did a project for the London SHA as was. So if people walk about an extra half hour a day, 4 or 5 days a week, they can walk 1 million extra steps in 4 years. So maybe the mayor would like to have a second Olympiad. And we would aim to have 2 million people walking an extra 1 million steps over the next 4-year period, and we'd do it probably with the telephone companies involved in some way to fund it.
Could I?
It'd be great to do it through the scale idea. Yeah. It's a wonderful idea. Really engage with younger children.
I love this idea, and Winston Churchill said you make a living by what you get and you make a life by what you give. And in particular, I think when you have a long-term condition that might mean you experience worklessness and other things, what happens is you get given lots, but it's not what makes a life. And I loved your suggestion earlier about linking a challenge like that to being able to raise money for a charity or a community elsewhere in perhaps a developing part of the world. There's something about most people need to give us something. So coming back to your point about motivation, I might do something like that for others. So I think linking it with something that really helps others might motivates many people. But I guess my second point is I think we don't pay enough attention to the psychology and the behaviours of staff and those of us who work in services. So we talk in this rather omnipotent way about behaviour change in patients, of which we all are, of course. But actually, I think in terms of scalability and how we change behaviour and how we open the world up so that something that works here, we do transport more quickly. There's something about the psychology of those of us working in services, which means we get very tribal very quickly. This is a well-known phenomenon. But I think we've got to stop just commenting on that well-known phenomenon and think very much about how we're training staff from the outset to think differently about the gaps and overlaps and how we manage and lead them in their jobs, because we all do, all of us, every single person in this room, revert to what we know and the walls around us very, very quickly. So there's something for me about how we train staff and the psychological mindedness we bring to the management of staff if we want them to behave differently on a grand scale.
I think one of the big tensions for us in services across health and care is how do you do the scale and systemization and standardization but still get that locality and that personalisation? That's the big challenge. And Triborough, which is those 3 London boroughs, has given me amazing opportunity to learn how to do the collaboration and scale, still keep that locality flavour. The CCGs, we've got a brilliant opportunity in London, in my view, North West London and you probably say Pan-London, around how they've supported each other and started to strategically work as a collective but still keep that locality. So for me, we local authorities need to find the commonality and the collaboration in the same way that the CCGs have. And how do we fund that? In my view, is we put our money together and we have a financial strategy that supports each other in our key priorities. And London is, if we can't do it here, it's a fantastic landscape, I think, to do some of this work.
How would you get the mayor to coordinate all of that? What do you think the mayor or the mayoral office needs to coordinate this activity?
I don't think I can answer that. Maybe other colleagues would like to answer that.
Yeah. Sorry, let's. Yeah.
Yeah, I'd just like to explore a couple of those themes in relation to tuberculosis, which is what we're particularly interested in. And I think on the TB side, what I'd really like to see from the mayor is for the mayor to say it's unacceptable that we've got so much TB in London. Yeah. We've got more TB than any other city in the westernised world. But when we then look at where we need to do to deal with that, there's a whole load of issues. And if I just pick up a couple which link to the things said earlier on, it's really easy for me to treat somebody with TB in front of me. I just give them complex drugs that they have to take every day for 6 months. When they don't manage to do that, when they fail, they're more likely to get drug resistance. That's more expensive, it's more difficult. It's a tremendous problem for them as individuals. And why do they fail? It's almost always complex psychological issues, social issues, housing. It's that maybe poverty. It's very rarely because they actually don't want to take their TB tablets, and we can't solve that unless we're working with everybody else from that point of view. And likewise, our other big problem is people coming to us too late, or people recognising they might be at risk for TB and needing to be treated or accessed or investigated. And a lot of people from that point of view, there's a lot of ignorance. And all of the partners we've been talking around here come into contact with the groups who are at most risk of TB and could be working in partnership right across the whole system to get a message out that we need to recognise and deal with it as a problem, get people coming forward for testing, and then we can treat them and we can support them after treatment. And that is really a whole system thing, and it's really what we'd be looking for, as I say, is for the mayor to say we have to do something significant about this, as opposed to sort of saying we need to fund something differently. A lot of the funding is there, but it's a question of getting people using what already exists.
Great. Could I just move on very briefly to another subject, which is about the benefits we've seen in centralising stroke services, which the Strategic Health Authority was extremely successful in managing trauma. And through the evidence hearings, we've come across some evidence to suggest that other areas like paediatrics and orthopedics might be 2 areas. Children will benefit from more specialist services to be centralised and a significant amount of others to be decentralised to the community. So having Professor Briggs here, I just maybe being at the orthopaedic, the president of the British.
Yes, it's interesting. I mean, orthopaedics is 33% of the surgical workforce is trauma and orthopaedic surgeons, and now 26% of everything that goes through the secondary care sector is related to T&O. So we are big players in a game that has a budget of about £10 million. And actually we're in a perfect storm, aren't we? We've got an ageing population. Prevention's great, but we've got a huge population that is going to get musculoskeletal problems, and we've got to find some solutions. And we're running a national pilot called Getting It Right First Time. I'm involved in visiting every single trust in England and have now visited many of the trusts in London. And there is no doubt I'm seeing significant variation in practice, seeing small volumes of specialist activity being carried out in trusts where it would be better for that work to be done in more centralised centres. And I actually think that London has a golden opportunity. We've got 23 trusts in London. We've got some fantastic specialist hospitals in London, including orthopaedic ones. And what we need to do is we need to provide a consistent level playing field of high quality and outcomes for our patients. And if you do that, and I'll just use infection rate as an example, the infection rate across the country and in London for primary hip and knee replacement varies from 0.2% to 4.49%. If you could reduce that across the country to 0.2%, at a stroke you will save every year almost £300 million. That would allow you to do an extra 60,000 joint replacements at no extra cost. So I think there is a great opportunity for the Mayor and London to drive a real high quality level playing field, getting the right patient to the right surgeon with the critical mass, with the volumes and therefore the best outcomes you can get with the lowest complication rate, and you would make massive savings, but the upside is you would improve the quality of care no end. At the moment we're seeing revision rates for hip and knee replacement. Knee revision knees in the last 5 years have gone up by 92%, and revision hip has gone up by 49%. And we've got to somehow get control of this. And I think there is, orthopaedic surgeons and the British Orthopaedic Association and myself as president, we are going to change, I think, the way we manage orthopaedics in the UK, and it will mean a more centralisation, getting the right patients, the surgeon with the right critical mass in the right environment to get best outcomes. And if you ask patients, actually, that if they go to hospital X and they're going to get a 98% chance of an X outcome, not infected, they're going to have high quality, high outcome with low complications. In my experience from the hospital I work in, patients are more than happy to travel that extra distance. And I think London could very well set the example with that, with all the healthcare facilities that we have in place.
Yes.
My day job, I've been publishing atlases of variation, and there's huge variation in everything in London. And the offer I made to the Commission was that we've been developing training resources, because what we need to do, you can't, I mean, fantastic what Tim's done. Actually, TB needs a bit more push, but it's organised, acute stroke. But there's another 30 or 40, skin disease, £200 million. We haven't a clue what's going on that. So my wife says I can work 2 more years at the rate of intensity I'm working at the moment. And the offer is to set up, I could maybe train a team of 25 people. There's probably 5,000 people who we need to get to change in a different way, the leadership of London. Half of them clinicians, the rest people like in the room here. But they have to think in a new way about value, about whole population systems, about culture change, and about personalisation. Yeah. So that's my offer to the London Commission. And I think we have some very good, actually excellent models. The Impress work on respiratory in London, the tuberculosis work, the acute stroke work, and Tim's work. But there's about another 26 businesses like that, and you can't do them one at a time. We need to think of a way in which we get maybe 5 or 6 teams just sorting it out.
Can I just ask, what's your view, Tim, about what the barriers to what you just described? So the clinical evidence is very, very compelling, isn't it? And we've got a good example out in southwest London of the very thing that you're describing, yeah. And patients love it, and you're right, they travel a long way to get there for the outcome that you're describing. So what is it, in your view, that gets in the way of that happening more widely?
I think 2 things. First of all, you see where the NHS was 5 years ago, it was all about competition. I think if we're going to survive going forward, we've got to be collaborative. All right. I think then you've got to get clinical buy-in. And the beauty about why I think Get It Right First Time will deliver is because it's a peer-to-peer review, clinically led by the president of the BOA, going to see all the trusts, and I've been to Ealing and other hospitals in London, eyeball to eyeball, talking to clinicians about their results and the data set we send them before we go. And once the data is there on the table, you can't actually argue with the data. So in London, we already know that I think you're going to need 7 units to do the work for Londoners, which will produce much better outcomes. And actually, if you think about it, what else will it do? Commissioners don't know whether they're commissioning 100 good hips or 100 bad hips. So let's get provision right, which is what I'm in, and we're about 80% of the cost in terms of what we do. And then commissioners will have confidence that whatever they buy, wherever they buy it, they're getting best value, best outcomes for their patients, and lowest complications. So I think people are different.
Tim, it's leadership. We need to have another 25 or 30 Tim Briggses. And there's maybe not other Tim Briggs around, but there are people. Yeah. William and Lynn have done it for TB. We just need to get people And because when you go in with these data, people go, oh, the data's wrong. Listen, sunshine, it's your data. Now let's talk.
It strikes me that I can see anybody who holds the mayor's position as the first citizen of London. And for what a number of you are advocating, if I'm the first citizen of London, isn't my role something to advocate on behalf of Londoners? And where Londoners are getting a poor deal, where Londoners' lives are compromised in some of the ways that you are talking about, there's the role of the first citizen on a call to action and a call to account. So where credible people can come forward with a serious evidence base that deals with the atlas of variation points, etc., and there is a solution, what you want is a bit of air cover. If something in the system is bogged down, which is what we all experience, you want somebody to turn around and say, do you know what, on behalf of Londoners, that's not bloody good enough. And I'm not going to let it go till something happens about that. Some, not me yet, touch paper, but some of the people around here have appeared in front of select committees in Parliament where on our behalf as citizens we are held to account, and it's not a very comfortable experience if you're defending the indefensible, frankly, in that experience. And there is a parallel sort of position that I think we could be thinking about. If the mayor was to go beyond a one-off commission with maybe an action plan which picks up one of these things, to turn around and say, actually, I'm going to build into the mayoralty that there are 3 or 4 things that really matter to Londoners, and one of them is getting our health sorted out. And the 4 things we have to do to get our health sorted out is we're going to change that stat on TV, we're going to do something about falls, etc. And when you think about all the MSK contributions that wider determinants can happen in planning and environmental terms, there may be a challenging function that gives people like you an opportunity to turn around and say, people can't hide, the system can't just listen to you politely and, 10 years' time we're back hearing the same old thing and not a lot has changed.
You're absolutely right. But I think that, I was talking to Mira about it earlier, that we are all in a bit of a pickle at the moment. We've got, as I said, our population's ageing, and we've got financial austerity, and it's not just here, it's in Europe, everywhere. So actually there's a golden opportunity when you have that to engender change that improves outcomes and actually saves money. Everybody assumes if you save money, it's going to be cheaper and it's not going to be as good. I think that is totally wrong. Now, in orthopaedics, we already have this project, this national pilot. In fact, Wales want it now, and Northern Ireland want it, and it is going to deliver what we need it to deliver. What you need the mayor to say is, we'll use this as the pilot in London, and it's there, and it's one of the biggest costs we've got with the ageing population. Run it through. I think it'll have engagement from all the trusts, medical directors, chief executives, and importantly the clinicians. From the evidence that I've seen so far, everything has been very positive, and I think the rest of the country will follow you.
Right.
I was really with James, and then when you started talking about action plans and some of the sort of smaller areas of specialisms, because I think actually listening to what would I like for the mayor, I would like themes and system leadership for London. And it is about system leadership, isn't it? And it also the thing that we've learned, which is fantastic in the whole systems programme, is the lay people involvement, the engagement with people who use the NHS and care services and who really passionately believe in working with us on it. So that sort of system leadership and champion of the big themes rather than that action plan. And
I wasn't advocating, though. I was saying there's a danger that you have run an exercise like this and what you're left with is an action plan and not something a bit more enduring. Action plans can achieve stuff, but they're rather
what's so
limited.
inspiring, I think, when you hear listening to people is that there is a very large leadership resource in London that's
needs mobilising.
working together, mobilising into a movement.
And one of those other units that you need to centralise is paediatrics, where we have lots of small paediatric units desperately need to come together, working together then with the schools and local authorities to improve fitness as part of that, alongside having fewer inpatient units.
It's not centralisation, it's systematisation. The strength of what he's done is what they've done in Sheffield. They called it Sheffield on the move, the musculoskeletal, because it started off with the citizens moving, and then there's hip replacement too. So, and the word centralisation is a dangerous word, as you know, but systematisation, which almost inevitably will result.
It has to be networks and
how do we make sure that happens across 32 local authorities in some of the big public health areas? So we provide HIV services, huge sexual health services, and some of our worries at the moment would be, and again they're hugely behaviourally linked as well, that potentially we fragmented the thinking to 32 very good London boroughs, and some are coming together and thinking together. But I am worried that this systematisation doesn't just happen around hospitals. Really important work happens in hospitals, but way upstream and hugely before that, there are some huge public health challenges that, whether it's TB, sexually transmitted diseases, HIV is on the up again amongst white gay men, and so on and so forth. And unless we systematise some of those approaches there, have the leadership there as well, I do fear that at the moment we could really fragment care. And I'm hoping the Mayor and this commission can act as a catalyst to ensure that some of those big programmes of health and staying healthy and that lead to ill health are tackled strategically and in a systematised way as well. So, for example, my sexual health services that are based in Camden but are open access potentially have over 85 different commissioners, all of whom want something different, and yet there's an expertise at the centre of all of that around sexual health services for children or older people or so on and so forth. I think the Mayor has to champion systems of care that don't just centre around hospitals, and hospitals are fantastically important. I want that too.
Can I just comment on that? Yeah. What I'd say is I totally agree with you, but you've got to start somewhere.
Sure.
And if you look at where the cost is, hospitals are a huge cost, 80% of the cost. So orthopaedics, we're 33% of the surgical activity really in hospitals. Yeah. So if you get that system right, and you get high quality, low complication, standard level, that will free up the monies, allowing you to move it upstream and downstream elsewhere in the community. Unless we get the hospital system right, we'll be back here in 5 years' time with exactly the same problem, but less money in the system, and we'll have rationing and we'll have decommissioning of services. So you've got to tackle it somewhere, and I think orthopaedics is there for the taking and is there to be piloted to see if you can do that, and I believe you can.
And orthopaedics is only partly the operation. The rest of it is the physio, the community work. And if you think about orthopaedics as a hospital specialty, I think you're probably missing it.
We do MSK in the community as well. I suppose I'm just seeing some big public health threats that will bring huge cost into the system quickly. So we set up a club drug clinic recently out of our innovation monies. It was inundated by gay men who were on the club scene, taking drugs, engaging in risky sexual behaviours, who desperately want to change those behaviours now. And they're going to be a big cost to the system so I wasn't saying instead of. I don't want that work to stop, but I think we can do some twin track work in the community as well.
Big opportunity to use some of the online, because there's a big identity in London and people move around London. So London health clubs, I know Change for Life do one, but you do online clubs, a lot of self-care. We are talking a lot about services and buildings, but actually the Mayor could do something about online London.
What about Transport for London as a place where you get some of your health messages in a digital kind of way as well? I mean, it's a classic pan-city place. Get them out there. People spend an awful lot of time on it.
And there's, you can do your drinks tracker and all that sort of thing. So, track your health on as a Londoner or something.
Yeah. Can the Mayor help on costing that? Because the issue I had some years ago on a TV programme across London was hugely expensive. I chose to put a message on buses that went across the deprived parts of London. It was really good. Lots of people saw it. But it was like £60,000 just for a few weeks. And it was a message that needed to be done on a regular basis. And it was seen by a lot of people. I got a lot of good work out of it, but it's just the sheer cost of using Transport for London. And I know they're going to make a profit, but how can we work with them so that we can do those things successfully?
That seems cheap for me.
Can I just check on? I talked about one of the roles of the Mayor as first citizen. Another role the Mayor can take is broker. We have represented in this room. It was talking to our sporting sector here, who represented from our Fulham Football Club. On that particular point, if you have a pan-London reach, you have a marketing opportunity for people who are interested in marketing, in the same way that Barclays Bank started out sponsoring the banks. one of the things the Mayor can do is try and mobilise and marshal the corporate social responsibility funding of our very big corporations around a set of themes or campaigns that are pan-London. And you might have struggled to marshal that because you'd have to go chasing all around them. And who are you? You know, in honest, and you're competing with about 7 bids. But if the Mayor was to turn around and say, look, there are 7 big themes that we're going to tackle in the next 5 years, and I'm going to mobilise and broker that CSR funding into those 7 themes, then your door is open to how we pay these kind of bills that isn't coming just off the NHS budget or some other hard-pressed budget that's in the public sector.
Great. Well, I'm just going to take a 10-minute break back here at 3:15, and please, whoever wants to stay, there's other members joining us. I'd love to continue the discussion. I really want to continue the discussion about how we're going to fund this.
Yes.
And the Mayor, who is a wonderful man, cannot do all of this. So I'm going to come back to Anne and say, okay, the Mayor could play a serious role in health and well-being, which, well, you can see the role he could play in that. But NHS-wise, what do you need beside a Mayor?